start on the different section of pharmacology. For this section, we'll be dealing with inflammatory bowel diseases. So inflammatory bowel diseases, and the two main ones are ulcerative colitis and your Crohn's disease. So today we'll be starting off with ulcerative colitis, and then on Wednesday we'll finish up with your Crohn's disease. Okay, we can step back and just quickly look at the GI. So for your gastrointestinal tract, it will start from the stomach as the gastro, and then you'll get to the small intestines, which we will call the DJI, that is duodenum, jejunum, and ileum. So the ileum will be the most distant part of your small intestines, and the ileum will empty into the large intestine, which will be your colon. So the ileum, the small intestine, will empty into the large intestine at the level of the cecum. That's where the ileum enters the large intestine. Down here below, you will have your appendix, and that's why you always say that you know a patient has appendicitis if they have that pain, severe pain that makes them double over, starting at the lower right quadrant. Okay. So we go from the cecum to the ascending portion of the colon, then the transverse, and the descending colon. And then the descending colon will take an S shape. So this part of the descending colon is called the sigmoid colon. And after you get out of the sigmoid, then you enter to the rectum and on out to the anus. So when we say ulcerative colitis, we're talking about basically an inflammation of the colon that ulcerates. In other words, you have like an open sore in there. So this will be the segment of the digestive tract that we'll be focusing in on. All right, so by definition, ulcerative colitis is an IBD, that is an inflammatory bowel disease or disorder that is characterized by inflammation and ulcers in the large intestine. So ulcerative colitis mainly affects your large intestines, all the way down to the rectum. It is a chronic condition, but it does not occur rapidly. It is gradual in its occurrence, and it can relapse after remission. In other words, if the patient has signs and symptoms of ulcerative colitis, there will be periods when they will not experience those signs and symptoms. And then it can come back. When they don't experience anything, that means the condition is in remission. And then when they start experiencing the signs and symptoms again, then it will mean that it has relapsed. And based on the location of the inflammation, you can divide ulcerative colitis into four main groups. Okay. So the first one is your proctitis ulceration. In that situation, the inflammation is confined to the rectum. So that's the only part that will be affected. And the number one, in fact, the only characteristic of that type of ulcerative colitis is your bleeding. That is rectal bleeding. That's the only thing that the patient would experience. Of course, they will run to the hospital anytime they see blood. So that's type 1. Type 2 is when the inflammation is not only present in the rectum, but it is also present in the sigmoid portion of your colon. And that's the one that's called the proctal, that is rectum, okay? And then sigmoid. You have the inflammation there. So that's the second type. And that could also lead to not only rectal bleeding, but also pain in the rectum, as well as in the sigmoid area. Okay. And one can see cramping in the colon, so that will be experienced by the patient. And when they feel, when they have an urge to defecate, nothing might come out, so they will have to strain, and that's what you call tenesmus. So tenesmus is always attendant when you have the proctosigmoiditis. Okay. And then sometimes the inflammation will not only affect the rectum, the sigmoid, but it will also affect a large portion of the descending colon. And that's the one that you would call left-sided colitis. And left-sided colitis will be characterized by everything that you can see in the proctosigmoiditis, but it would affect that larger area because it goes all the way through the descending colon. Okay. And it will be limited, of course, to the left side, which means that part of the descending portion of your colon. And then the fourth type is the pan, that is global, okay, pancolitis. So that, in that situation, you have inflammation affecting the entire colon, right from the cecum area all the way to the rectum. And the symptoms of what the patient will present with will be all of this, rectal bleeding, and pain, and cramping, and tenesmus will be present. And the type of diarrhea that can be present with your ulcerative colitis would have blood, so it will be bloody diarrhea, and it would also have usually some pus or mucus. Okay, so all those can be seen with your pancolitis. So those are the different types based on the location of the inflammation. Now, what is the etiology? That is the cause of ulcerative colitis. We will say that it is unknown, specifically or particularly. However, it is believed to be related to hereditary conditions. Okay, that's one. But most often it is due to an immune response that is not normal. Okay? So the immune system responds to a particular trigger or antigen, if you will, in a manner that is not usual or not normal. So that's all we can say about the cause of ulcerative colitis. However, we know that there are certain risk factors. The risk factors for ulcerative colitis, of course, would include familial risk factors, that is, a relative, a close relative, a first-line relative that has ulcerative colitis. You could, or you are at high risk of developing that ulcerative colitis. So that's familial. The other risk factor is age. It usually occurs in people that are in their 20s and 30s. That's when the initiation starts. Occasionally, and it has been reported in the literature, you can see an individual who is about 60 years old developing ulcerative colitis. But for the most part, it's in the 20s and 30s. So when you are within that age group, you are at a risk or high risk of developing ulcerative colitis. And then race. By far, ulcerative colitis occurs more in whites than in any other race. And in particular, it occurs in Jews, especially Jews who have East European origin. Okay. That's actually the group that has the highest incidence rate of ulcerative colitis in the whole world. Okay. That's a particular race that we call Ashkenazi Jews, ASK, Ashkenazi Jews. They have the highest rate in the whole world.
Does it have to do with the BRCA being common in that population as well?
Does it have to do with what?
With the BRCA gene being common in that specific population as well?
That's only part of it.
Okay.
That's only part of it. There's something that's also related to their diet and what they eat or not. People who indulge in the so-called Mediterranean diet would also have that characteristic like the Jews. Yeah. Okay, so those are the causes and the risks. And why would you want to treat ulcerative colitis? Because complications can occur. Okay, so we have complications of ulcerative colitis. The complications, of course, will be severe hemorrhage that can happen, and the severe hemorrhage can lead to severe dehydration. Okay, so that's another complication of ulcerative colitis. Perhaps the worst complication is what you call toxic megacolon. As you see, mega and then colon. The colon gets very enlarged and it gets useless. But this is always considered an emergency if it occurs, because it's life-threatening. So that's the worst complication of your ulcerative colitis. That's also one reason why we don't want to use loperamide or Imodium for managing diarrhea that is due to ulcerative colitis, especially if there's an infection involved. Because you very easily can get that megacolon, which now becomes life-threatening. And then you can get colonic perforation. So basically, that ulcer, it eats through the walls of the colon. So you have a perforation there. So colonic perforation is another complication. And then you get an increased risk of cancer. Your colorectal cancer. You see an increased risk if you don't manage that ulcerative colitis. And some other complications, sometimes you can see osteoporosis developing in individuals who have a long-standing ulcerative colitis. So that can result from that. And then you can have blood clots. You know, blood clots, if you have hemorrhage, the first thing that happens is that you have what you call a platelet plug. In other words, if you're peeling potatoes or whatever and you cut your finger, blood comes out, and then the blood will curdle. In other words, it will form like a scab. That's what you call a platelet plug. And once that platelet plug occurs, you are more likely to develop a clot behind it. So all that hemorrhage that you see can lead to the platelet plug, which can then result in your blood clots in the individual. Okay. So all of those can be observed, and then of course the severe inflammation, which can be associated with your ulcerative colitis, and then the possible infections that can also result. And if the bleeding continues, then of course you can have iron deficiency anemia due to the loss of iron during the loss of blood. So for those reasons, you actually want to treat your ulcerative colitis at an early stage. So how do you diagnose ulcerative colitis? Well, there are three main things that one would do. One, of course, will be imaging. You can do endoscopy, you can do colonoscopy, okay. And if it's in the sigmoid area, you would do what is called a flexible sigmoidoscopy. So all of those can be used when you're just looking at the colon. And you can, of course, have your x-ray being used to image the area. And you can also use your MRI to basically get a picture of the area. Okay, and then of course you can do a biopsy, taking the tissue out and seeing what the cells seeing the presence of inflamed cells or cells that are related to the immune system that would abound in that area. Okay. So the signs and symptoms can also help one in terms of determining or diagnosing the ulcerative colitis. Signs and symptoms of ulcerative colitis, those are what we've been developing here. So we can see all of these are signs and symptoms, and sometimes fever can be present. And once fever is present, you know not to use your Imodium, because that will suggest the presence of an organism, and then the patient will most likely get that toxic metacolon. But anyway, you can have fever, you can also see some people rash, and then fatigue can be present. And then, of course, you can see weight loss in these individuals that have your ulcerative colitis. Okay. Then you go to treatment. For treatment, you just have two things you can do. You either do surgery or you use drugs. Okay, for surgery, they can take out the colon. So they can do an ectomy or resection of the colon. That's mainly the only thing one can do. Sometimes you have what is called Escherichia coli anastomosis. That's when the whole colon is taken out, and then a pouch is formed that will connect the small intestine straight to the rectum. Okay. And that way, the material within the small intestine can just go straight to the rectum after whatever we need has been absorbed through the small intestine. So that's how you resect or do surgery to manage ulcerative colitis. And when that anastomosis is not present, sometimes you will see the patients with a bag, that they can excrete through. And so we go to drugs. And there are some classes of drugs that are used. The first one you see there is 5-ASA. That is 5-amino salicylic acid. That is not aspirin. It's not acetyl. It's 5-amino salicylic acid. And compounds that belong there will be your azophenate, which we have discussed in order 2. That's your sulfasalazine. And you see in there, that little ASA is in the generic name, sulfasalazine, amino salicylic acid. So that's one of them. Now salazide is another. And then you have your mesalamine. Also, we've discussed the sulfur drugs in 42. But what is worth mentioning here is that if a patient is, if a female is taking sulfasalazine for the management of ulcerative colitis, they have to ingest, along with it, folic acid. Because we know what sulfur drug can do to your folic acid levels. It can deplete your folic acid levels, so you have to administer, especially if it's a pregnant woman. And another thing that stands out about sulfasalazine is that it can decrease not only sperm count, but also sperm function. Okay. So those are things that stand out about your adopted. But when you say mesalamine, you have some specific products that fall under that group. For instance, your Asaco, that's one example. Canasa is another one that is a mesalamine product. Rowasa is another example that we can give. Lealda would be another one. There's this here as an enema that one can use. You use Rowasa enema if the patient has that left-sided colitis. You know, the third example that we gave in terms of types of your ulcerative colitis. Aprisol, you can also see as an example. That's one also called Pentasa. Many of them, you have that ASA involved in the name. Okay. Now, overall, mesalamine, we say, can be administered either orally and can be administered as a rectal agent, either as a suppository or as an enema. And you can also see it in the foam form. So those are different routes of administration of your mesalamine. In terms of the mechanism of action of mesalamine, there are about 3 or 4 now that have been universally accepted. One, we know that it can inhibit natural killer cells, and it can inhibit your TNF alpha, tumor necrosis factor alpha, and it can inhibit your nuclear factor kappa B. Can inhibit all those. It's a strong antioxidant. And it can serve as a scavenger for your free radicals. That's another mechanism of action of your mesalamine. And it can interfere with the production of prostaglandins and leukotrienes. See, prostaglandins and leukotrienes are mediators of inflammation. So if you can decrease the production of prostaglandins and leukotrienes, through your cyclooxygenase pathway and your lipooxygenase pathway, then you are reducing the amount of your pro-inflammatory cytokines in the body. So through all of those mechanisms, your mesalamine can reduce inflammation, and you take away inflammation from ulcerative colitis, you manage the colitis. The half-life of mesalamine is taken to be about 25 hours. And the plasma protein binding is in the 40s. It's taken to be about 43 to 46 percent in terms of the plasma protein binding. It undergoes N-acetylation in the liver, so that's the metabolic pathway. And it is excreted both through the renal and the hepatic pathways. So liver and kidneys. That N-acetylation can occur in the liver, that is the metabolism, but it can also occur in the GI tract. So it's not only just in the liver, it can go on in the GI tract in terms of the N-acetylation of that drug. And when you look at the general adverse effects of mesalamine, it can be nephrotoxic, it can be hepatotoxic. So if the patient is going to be on it for a while, you have to do a renal function test. Okay. And then, of course, a liver function test would also have to be done. It can give you myalgia and arthralgia, and it can give you, of course, some non-specific GI symptoms, nausea, vomiting, diarrhea, anorexia, and so on, can be present with your mesalamine. Sometimes pancreatitis, can result from therapy with your mesalamine product. So we took that as a representative of your 5-ASA products. And then, of course, we can go to the next group there. And the next group we've done in order 2 also. Okay. So, deltazone, of course, which is prednisone, and then budesonide, which you can see as your Entocort EC. So we've done those in your order 2. So 1, 2, and 3 are considered your anti-inflammatory agents that you can use in the management of ulcerative colitis. And then we go to immunosuppressive agents that you can use in ulcerative colitis. So 4, 5, and 6 are immunosuppressive agents. Azathioprine, which is your Aimeron, is actually a prodrug for your 6-MP, 6-mercaptopurine. And so if you give your 6-MP, it can inhibit the de novo synthesis. The de novo synthesis of your purine analogs. So you have a decrease in your purine nucleobases, and then of course nucleosides, and so you can then see a decrease in any synthesis in those cells within the colon where you have the ulcerative colitis. So basically you will be reducing the immune response. That's what I say, immunosuppressive agents. And since we mentioned that one of the etiologies of ulcerative colitis is the abnormal immune response, these three agents will take care of that. Cyclosporin, you can see as Neora, that's one example. You can see that San-Immune, that's another brand name. That would inhibit calcineurin. And when you inhibit calcineurin, you can actually see a decrease in the production of your T cells, particularly, and then you can see a decrease in the production of interleukin 2. Interleukin 2 is another cytokine that can be pro-inflammatory. So it's pro-inflammatory, so if you decrease its production, then you see a decrease in inflammation. So those forms we've seen. Let me just rule these ones out. Your anti-diarrheas, so we'll do those somewhere along the line. The one that will be used if you have a severe diarrhea will be your loperamide. But if there's a fever or infection, we don't use that. We'll go to your bulk laxatives, like Metamucil. Your bulk laxatives are normalizers. Your bulk laxatives can be used for both diarrhea and constipation, because essentially what they do is normalize the GI medium. So if you don't want to, or if you cannot use Lomotil, you can use your Metamucil. Analgesics, because we mentioned that there's pain associated with ulcerative colitis, then of course you can use something for the pain. You will not use an NSAID, that can worsen the situation. And so in that situation, you have to use your Tylenol. And because that will not irritate the GI tract, so that will be the preferred agent in that situation. Okay, another one we can cancel out right away, antispasmodics. We've done that under your ANS. So will be your anticholinergics that have antispasmodic effects. And that is because of the spasm that you see in the colon when the patient has that ulcerative colitis. So let me see anything more about those. One that we can quickly pick out. Baricitinib. I'm sure you've seen on TV Rinvoq. Okay. Upadacitinib is a JAK inhibitor. And another JAK inhibitor on this list is tofacitinib. That's Xeljanz. In the cells, within the cytoplasm, you have some tyrosine kinases. Okay. These are not receptor tyrosine kinases. These are cytoplasmic tyrosine kinases. So they're not on the outside. They're not activated by, this receptor that goes through the membrane, and then on the inside you have tyrosine kinase activity. But these are cytoplasmic tyrosine kinases. And there are four major ones, that are involved in this pathway. You have JAK, and JAK means Janus kinase. Okay. So you have JAK1, JAK2, JAK3, and then you have your CTK2, cytosine kinase 2. Those are four cytoplasmic tyrosine kinases. And what the JAK proteins would do, they would phosphorylate, which basically means activate your STATs. And STATs are also other proteins within the cell which affect the activities of your immune cells, and which also affect gene production or generation. And so your JAKs will phosphorylate your STATs, and then that will lead to the generation of genes. It will lead to the control of production of cells within the body, that is your hematopoiesis, and would also lead to control of your immune cells. Okay. So the JAK-STAT pathway is a signaling pathway, that would affect your activators of transcription. Okay. Maybe we should write this out. It says signal transducers, that is the ST, and activators of transcription. So that's what the STAT stands for. So your JAK proteins will activate or phosphorylate the STATs, and then the STATs would affect gene production and hematopoiesis, and then the function of the immune cells. So basically, if you can inhibit JAK proteins, then you can reduce or inhibit all this transcription, and then you can inhibit the immune cell functions. And if you inhibit the immune cell functions, then you will not have that immune component of your ulcerative colitis. And that's how those work. maybe I can say a word or two about JAK inhibitors. And then we just do the rest next time. So if, for instance, we look at tofacitinib, that is Xeljanz, this one to represent your JAK inhibitors. It inhibits mainly JAK1 and JAK3. Okay. So those are the primary targets of Xeljanz. And through the inhibition of JAK1 and JAK3, it can block the actions of your interleukins. Interleukin 2, interleukin 4, interleukin 15, and interleukin 21. And by blocking those interleukins are pro-inflammatory. So if you block the actions of those interleukins, then you decrease inflammation. And of course, that will be beneficial to the patient that has ulcerative colitis. Xeljanz, the usual dosage is about 10 milligrams. That's what you start off with. 10 milligrams on a BID basis for 4 to 8 weeks. That's the initiation. And then you can maintain the remission, if you will, with 10 milligrams, 5 milligrams, and that will be administered on a BID basis the rest of the week. Okay. But you have Xeljanz XR, which of course is administered instead of a BID, it's administered on a QD basis. It's administered on a QD basis. And you can see it in 22 milligram strength. You can also see it in the 11 milligram strength. So you start off with a higher one for 4 to 8 weeks, and then you come back to 11 milligrams on a QD basis until the condition clears up. Xeljanz can have a half-life of 3 hours, but the XR, the half-life is 6 hours. And the plasma protein binding is beginning in the 40s, it's about 46%. And excretion is primarily renal for your Xeljanz. And it can be used for for more than ulcerative colitis. You can use it for rheumatoid arthritis. You can use it for psoriatic arthritis. You can also use it for ankylosing spondylitis. Ankylosing spondylitis. And basically, what that means, of course, itis will be inflammation. Spondyle will refer to spine. And ankylosing means stiff. Okay. So it will be an inflammation of the spine that is characterized by stiffness. So it can be used for all of those, and of course, since we're talking about ulcerative colitis, that would be a major indication for this drug. In terms of its adverse effects, What one has to be careful about will be is lipid profile, because Xeljanz can give you an increase in cholesterol, in your LDL, but in a way that's somehow good. It can also increase HDL. So you can see an increase in those, but it will elevate blood pressure. Okay, it will elevate blood pressure. And you have your non-specific adverse effects that it can produce. Upper respiratory tract infection is another notable side effect of this drug. Gastroenteritis can be there. Rash, you can say rash with that agent. Anemia is another adverse effect of the drug. And usually any drug that affects the immune system like this, you always have to be cautious of infections. TB, you have to make sure the patient does not have active or residual tuberculosis. And you can, of course, also see an increase in your viral infections when you are taking that drug. Okay. We'll hold it there. Continue tomorrow. Okay. Questions? No questions? So on Wednesday then, we'll go to, so upadacitinib is covered under your JAK inhibitors. And so we can go to the ones that are called small molecules. 10, 11, and 12 are classified as small molecules. And, all these ones, the TNF alpha inhibitors, those ones are classified as biologics. And that can also include ustekinumab and mirikizumab. So these will fall under your biologics.
So they would be called small molecule biologics, would be like the full, they're just made by a biological way, but they're called small molecules.
No, the small molecules are a little different from these biologics. You're getting more specific